Dear Pure Urology viewers, good evening, one and all. Today our talk is something interesting. In the recent past, lot discussed about this topic, benign prostatic hyperplasia and sexual health. As you all know, benign prostatic hyperplasia may start around 50 years and it keep on increasing its symptoms in the form of LUTS. At the same time, most of the men, testosterone decreases, sexual desire decreases, erectile function will be there, erectile dysfunction can be there. When you are treating BPH, these are all very important, right from the alpha blocker or in combination or the surgery. We have to keep in mind the sexual health. Is there any relation how they go together? Let us listen from Dr. Mohsen Elmekresh, who is from Abu Dhabi. I thank Dr. Mohsen for giving this opportunity to talk in the pure. I will share about his biodata briefly, and he is talking on impact of BPH and LUTS on sexual function by Professor Mohsen Elmekresh. He is the Professor of Urology, Head of the Department of Urology and Men's Health Center Medicine, Middle East Mediclinic, Middle East, Abu Dhabi, United Arab Emirates. He is consultant and head of the Urology Men's Health Mediclinic, Abu Dhabi, an author of numerous peer-reviewed publications and is reviewer and member of many international scientific committees and urological associations. He is Spectrum, just now I was talking to him, he does most of the urology, especially pediatric urology and kidney transplantation, both cadaveric and live donor. Apart from that, he is interested in the uro-oncology where ileal diversion is also his interest. He is member of various societies like Egyptian Medical Syndicate, Egyptian Urological Association, European as well as American Urological Association, European Society for Organ Transplantation, and member of German Urological Association, etc. On his name, the honors and awards are winner of the first prize for the best research in the 24th annual meeting of Egyptian Urological Association 1989, award of the Ministry of Social Affairs Abu Dhabi UAE, winner of the first prize for the best research in the 28th annual meeting of the Egyptian Urological Association 1993, Emirates Urological Society Scientific Award 2016. That's good to know about the academic career of the professor. Let us listen from him the relation between the BPH, LUTS, and sexual health. Thank you very much, Mohsen sir, professor.
Thank you very much, Dr. Chandra. It's my pleasure now to be with you. I'm a big fan of Pure Urology. I'm following you. And thank you very much for yourself and your team for the major effort in raising the awareness and the knowledge of urology, not only in India, but across the globe. Thank you so much.
Thank you. Thank you, sir.
I will share the screen right now.
Yes, sir. Yes, sir. We are able to see the screen. Yes.
Okay.
Yes, sir. Very good.
I'll just make it full screen.
Yes, sir. Thank you.
Today, as Dr. Chandra said, we'll talk about impact of LUTS, BPH on sexual function. When I started preparing about this topic, what is special for this group of patients who have BPH and under treatment or not to have sexual dysfunction? So is it physiological aging like normal? Is it a comorbid risk factor that make this group of patients have sexual dysfunction? BPH, psychological burden and reduced quality of life? Is it a link between LUTS and ED independent of the age and comorbidities we said before? General medication induced? Medication for BPH itself or even surgery can do some sexual side effect or maybe combination of the above. So in the next few minutes in my presentation, I will go in each of these points. Aging. According to the Massachusetts aging study, nearly half of men, they have some sort of erectile dysfunction, maybe minimal, moderate, or complete. And of course, erectile dysfunction will increase by aging, as you see right here. Why in this age group? Because it's not only the prostate, but in this elderly patient, they have some cardiovascular disease, maybe depression, and other comorbid factors. And this is a multi-center survey of aging men, around 13,000 men aged from 50 to 80 years in European and USA countries. As you see here, by aging, there is reduced here, wherever you go here, there is reduced or no erection or reduced semen or no ejaculate. And by aging, there is reduced sexual activity as well. Risk factors. There is a multiple risk factor in this age group of patients, but I highlight the most common risk factors, which is diabetes, hypertension, and cardiovascular disease. Metabolic syndrome is another component in aging men with BPH, and any of the three of the following five, when they are there, there is metabolic syndrome. Central obesity with increasing waist circumference, high triglycerides, HDL, high blood pressure, or fasting blood sugar. Usually, metabolic syndrome is associated with many comorbidities like cardiovascular disease, diabetes, fatty liver, etc. But for us today, is highly associated with hypogonadism, which is low testosterone, and erectile dysfunction. And this makes us think many times about the triangle of men's health. It's a triangle. One component is metabolic and cardiovascular disease. The other angle is testosterone deficiency, and the third angle is erectile dysfunction. People with metabolic syndrome, they have low testosterone in 30% of them, compared to only 13% in the normal population. And again, erectile dysfunction can happen in 27% of patients with metabolic syndrome, compared to only 13% of the normal population. The more the components of the metabolic syndrome, the more will be the incidence of erectile dysfunction. For example, if you have only 3 components, the incidence will be 18%. This will jump into 37% if you have all the 5 components of metabolic syndrome. A man with hypogonadism, they have very vague symptoms. He will go from one doctor to the other, a healthcare shopper, because he has lethargy, inability to concentrate, sleep disturbances, irritability, and above all, loss of libido and erectile dysfunction. General medication is the most common cause of erectile dysfunction in men above the age of 50, because by default, they are polymedicated and they have a lot of comorbid factors. Look at this one. A very huge list of medication that can induce erectile dysfunction. And most of these medications are taken by us when we are 50 and above. Antihypertensives, diuretics, cardiac or circulatory disease medication, tranquilizers, anticholinergics, antidepressants, hormones, H2 antagonists, and of course, chemotherapy. Pathophysiology. When we have any of the risk factors we said before, like diabetes, hypertension, etc., it will result in endothelial cell damage. And this will go into affection of multiple organs, one of which is the erectile dysfunction. And why erectile dysfunction is coming too early compared to the other cardiovascular disease. It's the rule of 2. Listen to this very carefully. The penile artery is one of the smallest arteries in the body. And when the diameter of the penile artery reaches to 2 millimeters, the amount of blood going to the penis is not sufficient for erection. So you will have erectile dysfunction. The same scenario will be repeated in your heart, but the coronary is larger. When the coronary is 4 millimeter, will go into angina or MI. And the same repeated in your brain. When the carotid reaches to 6 millimeters, then you will have transient ischemic attacks or stroke. What does it mean? Now, 2 for the penis, 4 for the heart, and 6 for the brain. What does it mean? When you have erectile dysfunction, he is telling you, take care, the next is your heart. And when you have erectile dysfunction and the angina or mitral or infarction is telling you the next is your brain. So diagnosing erectile dysfunction is not about sex and erection, but rather detecting early risk factors for cardiovascular disease. And you have the golden window between having the onset of erectile dysfunction and MI, which is around 2 to 3 years. So don't wonder when you have a young patient coming to your clinic, you discover any underlying factor, and one of them is to refer him for cardiology assessment because it may be the early symptom or manifestation of coronary disease. Psychological burden of BPH itself can induce sexual dysfunction. See at this. A patient living with BPH and LUTS is living today with bother, interference with his daily activity, sexual dysfunction. He is worried with a huge impact on his physical and mental health, and of course, personal relationship. And for tomorrow, he is afraid of potential progression of BPH that can end up either with acute retention of urine or need of surgery. So in a domain of 36-item health questionnaire in AOA, the lower urinary tract symptom is associated with a broad impact on the physical and the mental aspect of men's health. So eroding the role, the physical limitation, social functioning, energy and fragility, body pain, role limitation, mental health, physical functioning, and even health perception, all are destroyed by LUTS. Of course, the quality of life is more affected by the severity of LUTS, comparing the mild, moderate, and severe. The higher you go with severity, the higher will be the affection of the quality of life. Again, severity is very important. The erection problem is going hand in hand with the age of the patient and severity of lower urinary tract symptoms. Again, ejaculatory dysfunction is going hand with the age of the patient and severity of LUTS. Last but not least, the reduced sexual activity is going down by aging and with severe LUTS. This makes most the famous philosophers comment on the sexual health as an important part of our life. I'm just quoting 3 of the most famous philosophers. Rosen et al., he said reduced sexual activity is common in the majority of men above the age of 50 and is an important component of the overall quality of life. Although, because the inability to function sexually can erode the individual's sense of self-esteem and lead to emotional and marital tension, is not surprising to find the quality of life is diminished in men with erectile dysfunction. Last is Fogelmeyer, who reported using factual analytic technique, satisfaction with sexual life was found to be a powerful predictor for satisfaction with our life as a whole. So don't miss this one because sexual dysfunction is affecting the man. And not only the man, the partner, his wife is also affected. Look at this one. These are factors affecting the partner of a man living with BPH. Psychological burden, inadequate sexual life, sleep disturbance, disruption in social life, inability to take care of the essential tasks inside and outside the home, fear of prostate cancer, and the fear of surgery. And when you go here, spouses of men with enlarged prostate are more affected than a man with the bothersome symptoms. Look at this one. This is a man with mild and moderate and severe, and the green is the wife. So the wife is highly affected by lack of physical intimacy, anger or conflict, avoidance or withdrawal, feeling a distance from the husband, and the lack of communication. The third item is there is a link between LUTS and ED. Yes, we have clinical pathogenesis and epidemiological evidence that ED and LUTS are highly related to each other. Look at these risk factors. Both ED and lower urinary tract symptoms are sharing the same risk factors, which is age, sedentary life, lack of exercise, smoking, and alcohol intake, depression, insomnia, hypertension, cardiovascular disease, hyperlipidemia, diabetes, obesity, hypogonadism, prostatic disorders, and inflammation. So the physician should be aware of this risk factors, sharing ED and LUTS to manage the patient holistically, considering the two when you have the risk factors. Again, there is hundreds of evidence, epidemiologic evidence of the relationship between ED and LUTS, and this is some of the literatures in this one. Pathophysiologically, both ED and LUTS, they are sharing the same underlying pathophysiology, which is the reduced nitric oxide CMG signaling, chronic inflammation, steroid hormone imbalance, autonomic hyperactivity, pelvic atherosclerosis. All these mechanisms will result in reduction of the function of the nerve and the endothelium, altered smooth muscle tone, arterial insufficiency and reduced blood flow, increased smooth muscle cell proliferation, of course, will lead to BPH, LUTS, ED. So they are sharing mechanism of occurrence. This makes you aware risk factors, the association between both. So when you have patient in your practice with LUTS and BPH, please go proactively and ask about ED and other way around. In this case, you will be enabled to find an integrated and comprehensive treatment program treating the two diseases, maybe with one medication as BDE5 inhibitors, 5 milligram. Second thought was BPH medication. Is there any side effect of BPH medication? This is very interesting study. When they started asking in a survey, urologists and GPs, about the incidence and prevalence of sexual dysfunction among BPH patients, urologists, they said 19%. GPs said 27%. This is very low compared to the epidemiological evidence, which is 55 to 70%. They repeated the same question again. How do you think the prevalence of sexual dysfunction caused by BPH medication? Very high. Ejaculatory dysfunction, 32% by GPs, 22% by urologists, and the same with erectile dysfunction. So they start to re-emphasize again when first prescribing medication for BPH. When you start to counsel the patient about sexual dysfunction, it will raise the incidence by 3 times. So when you prescribe medication and telling him, look, sir, this medication may cause this, and say, no, I have already this, and I have already this. So please, when you first prescribe any medication for BPH, kindly ask about sexual dysfunction, because this will raise the incidence 2 or 3 times. And these are the factors why doctors are underestimating or underdiagnosing the relationship: lack of time, embarrassment, lack of confidence, respecting patient privacy. They are not asking about sexual function, difficulty in knowing how to ask, or conservative sexual beliefs, maybe insufficient knowledge on sexual health, or insufficient acceptance of patient's special sexual profile, and lack of awareness of the link between. Please, now you are aware, you have to ask, you have to consider the risk factors. From the patient side, he is not speaking up, especially in areas like the Middle East. Is still considered as open discussion of sexual problems is a taboo. They consider it an acceptance of part of aging, believe that symptoms are mild and self-limited, embarrassment, ignorance regarding the source of help, low expectation of treatment, fear of invasive procedures, maybe fear of the high cost of treatment. This is most common medication we are prescribing every day in our practice. Alpha blocker selective and non-selective, 5-alpha reductase inhibitors, finasteride and dutasteride. Look at this one. None of them, one way or the other, is exempted from sexual side effects, starting from erectile dysfunction, ejaculatory dysfunction, lateral ejaculation, or released libido. When it goes to combination therapy, this is the most common randomized control studies: VCOP, Alpha study, PREDICT study, M2, COMPACT study, and CONDUCT study. So when you go for combination therapy, the incidence of sexual dysfunction will go higher, of course. This is very important publication on how to monitor the impact of combination therapy in the sexually active men with BPH. So a prospective randomized placebo-controlled study studying the impact of fixed-dose combination therapy versus placebo in this case. So they will observe for a change in the sexual function from the baseline to months of 12. And of course, they measure it at months, first month, 3 months, 6 months, and 9 months. So they accepted 16-item questionnaire composed of the 3 components, domains, 1 domain for erection, and the score is 0 to 15, ejaculation 1 to 35, satisfaction 6 to 30. So in total, the questionnaire is around 7 to 80, and the higher the score, the better will be the sexual function. What they found? Sexual function is going slowly down, starting from first months and continued up to 12 months when you have combination therapy. Ejaculatory domain is also going down, which is more evident than the first one, which is a total sexual function. Erection domain is going down, and the satisfaction in overall is going down. When they go months by months, they found that the most affected is the ejaculation. It started significantly from the 3rd month and continued up to 12 months. And this is the overall picture right here. This is the summary of the men's health questionnaire about the satisfaction with the 6 items, which is ejaculation, erection, satisfaction, sexual activity, sexual desire, and bother. Look at this one. So the changes with the combination arm is mainly in the ejaculation domain compared to the other 5 factors. So ejaculation is the mostly affected sexual function in men with combination therapy. And they started, what is the mechanism of this? Why combination therapy is going to reduce ejaculation? Of course, retrograde ejaculation we know about from alpha blockers, but when you have 5 alpha reductase inhibitors, they have 2 mechanisms in reducing the ejaculation. Number 1, decrease the dihydrotestosterone level, which may be associated with this, and again, androgen-induced or stimulated nitric oxide synthetase expression. Don't forget that 5-alpha reductase inhibitors will lead to atrophy of the glandular epithelium. So it will reduce the amount of semen by 30%. About recoverability, they looked after, okay, we'll stop the medication. Is the side effect, sexual side effect after combination therapy will come back again? They said, look at this one. The number of ejaculatory disorders not resolved after 12 and 18 months. This is the combination arm. Ejaculation disorder after 12 months, 44% are still with ejaculatory disorder and 23% after 18 months. However, erectile dysfunction is recovering rapidly. Only 18% are not recovered in this arm and 13%. So, from this study, ejaculation is the most affected and the last to recover after combination therapy. Even if you decided to do surgery, there is none of the surgical technique is 100% away from the sexual dysfunction, whether you are due to URP, holmium, laser coagulation, incision, vaporization, hormone prostatectomy. Look at this one. The green is the sexual dysfunction of ejaculatory dysfunction, followed by erectile dysfunction. So in conclusion, the link between BPH and sexual dysfunction is well established and is increasingly prevalent in the men population as it ages. Shared risk factors should be assessed and addressed to treat the patient holistically. BPH is an independent risk factor for erectile dysfunction. Sexual dysfunction is a complex phenomenon which is not only limited to ED. Patients with LUTS should be asked about symptoms and both conditions at the first contact. And again, it's a huge burden for a patient and his partner. Management of patients with BPH LUTS include assessment of the sexual function, patient age, and the effect of medication. Thank you so much.
Thank you very much, Dr. Mohsen. Can we have some questions? If we close the screen, then we will have some questions.
Just give me. Stop sharing.
Sir, I wanted to ask, if somebody healthy and start developing erectile dysfunction, irrespective of LUTS, should there be a caution of the cardiac health? Is it an indication for TMT or cardiac evaluation? I'm not asking guidelines. Is it that severe that if a normal person suddenly loses his erection around 55, 60 years, he should be concerned about his cardiac health?
I personally, in clinical practice, yes, I do. I send him for risk stratification again for cardiology, because we have low risk, which is very clear, and high risk, which is very clear, patient with a history of stenting or MI, etc. But in the middle, which is moderate risk, it should be re-stratified again into low or high risk. Although, what is written with the common medication like sildenafil, tadalafil, etc., they have no effect on the cardiac function unless they are taking concomitantly with nitric oxides or the nitrates. But if you do spacing with half-life 6 to 8 hours, you can still take it. And that's why we are escaping now from this and replacing it with tadalafil 5 milligram, which is taking on a daily dose, low side effect, with very safe profile on the heart. But I personally, yes, I consult cardiology.
Yes. The second question, the LUTS are treated traditionally by adding the mirabegron, sulfenacin, tolterodine, all these groups. But recently, tadalafil, they are telling that LUTS will significantly improve apart from sexual dysfunction. They say that if you add low doses of tadalafil, it will have impact. Do you have any personal experience where if you don't add mirabegron or the tolterodine or sulfenacin, add only tadalafil, they say that your psychology will improve, your LUTS symptoms will improve, and your morale, your sexual performance, overall health also will improve.
100%.
100%.
100%, I agree with you, and this is supported not only by experience in the clinical practice. Tadalafil 5 milligram is reducing the storage symptoms, irritability, which is frequency, urgency, and nocturia. There is one paper published last year about the effect of tadalafil 5 milligram on nocturia, and there is a major difference between tadalafil and the control group. Number two, there is head-to-head comparison for the first time in a multi-center meta-analysis comparing tadalafil 5 milligram with tamsulosin head-to-head, for the first time. And the conclusion of this study, tadalafil 5 milligram is not inferior to tamsulosin in terms of relief of the obstructive symptoms. So we have one molecule treating obstructive symptoms, treating the irritative or storage symptoms, and improving the sexual life of the patient and increasing his moral. I think tadalafil 5 milligram is changing our practice.
That concept has come now into the practice all across the world. I think this molecule will be used by many of the youngsters in the future for the benefit of the patient LUTS and sexual function as well.
100%. You know, now it's in the guidelines, even when the criminology doctor, they give it routine to improve the endothelial health.
Yeah.
So all the endocrinologists.
And the future talk is even general health also can improve by taking tadalafil is the controversial discussion going on. Maybe
right.
The erectile dysfunction can be postponed. As we all know, erectile function is the most important thing for good health, both mental as well as psychological as well as physical health.
Absolutely. Even they changed the guidelines. You remember when they launched it first FDA approved for BPH with ED.
Yeah,
Now BPH with or without ED. So you can give it as a monotherapy
yeah,
with or without ED.
without ED. My third question, I have seen by adding dutasteride, theoretically, the patients who have good erectile function should complain that their erection has decreased, but majority of the patients don't complain, even after adding dutasteride. I repeat, the patients who have good erectile function, they don't mind taking combination of tamsulosin and dutasteride. Is it that the sexual potency is more and the dutasteride is not able to affect, or there may be other mechanisms which are involved? But certain people who are on borderline will say, as you said, ejaculatory dysfunction is the major concern for many, not the erection, those who are doing well. Let it be 60, 65. I hope you got my question.
I agree 100%. So erectile dysfunction is not the main concern of those patients rather than ejaculation. Decrease the amount of serum and decrease the ejaculate. And usually side effect as per the book, they started to appear after 1 year of using this medication continuously. In our practice, we don't see it as much as unless the patient is psychologically affected, that he is taking two medications and you start to tell him by yourself education. Part of your education will help a lot. So educating the patient is the most important.
Yeah. My fourth question, which drug, alpha blocker, you feel that has less retrograde ejaculation? I personally feel it depends on the each patient as well. Some say with tamsulosin very less. Some say with silidolsin it is more. We say that alfuzosin is better, but some say it is causing retrograde ejaculation. Even if you change the company with the same dosage, sorry to say, no conflicts of interest, that if I use the Cipla company, sometimes they don't complain. And if I say other company, it may, or vice versa, anything. It's not the question of company. So there is something else which brings significant ejaculatory dysfunction. So what is your opinion? I'm asking your personal experience as well as the academic data which gives the answer.
So the highest ejaculation problem is with the silidozin, of course.
Silidozin, yeah.
Because silidozin, the affinity to alpha-1A blockers is 160 times to 1 compared to alpha-1A to B or D. And with silidozin is not retrograde ejaculation, it's a lack of emission. The seminal vesicle is not contracting, is paralyzed. So in silidozin, it may be 0. And if you remember in the old literature, silidozin was used as contraception for men.
Yeah.
Because no single drop of semen will come out. It's an ejaculate. An ejaculate. So with silidozin is a different story because is lack of emission. But when you ask me when you are prescribed silidozin, I tell you in an old fragile man, and I am afraid of orthostatic hypotension. He has zero effect on blood vessels. So if you have an old fragile man,
Yeah.
and you are keeping away from hypotension, give him silidozin, of course.
Yeah.
Now, among the other alpha blockers with lower affinity to alpha-1A blockers, as you said, alfuzosin, as written in the book and the literature, is the least to reduce or to decrease retrograde ejaculation. But again, your observation is highly respected because we noticed this one. And with the current era now pushing a lot of generics in the markets, you have one molecule and the 3, 4 other molecules, and the patient himself will discover. Because doctor, I went and they changed this one. I found this one better, this one.
Yes,
This
yes.
is absolutely right. Absolutely right.
Yeah. My fifth question. Apart from the bladder neck, which we focused many years, we focused on bladder neck smooth muscle in the BPH. Now the same smooth muscle is there in the lower ureter, that is there in the mid prostate, that is there in the apex, that is there in the external sphincter around, that is there around ejaculatory duct, that is there in the seminal vesicles also. So all these behave differently with different alpha blocker. We are not talking about dutasteride. We are talking about only alpha blocker. If in that does it, do you think in future we may target typically the LUTS versus sexual function separately and use accordingly, maybe in near future? Now we are saying alfuzosin is okay, this aspect, but you are saying single drop of semen does not come if the seminal vesicle does not contract. Forget about retrograde ejaculation. So there may be many receptors which are not known to us. What is your preference if the patient is very, very particular about sex, very, very particular about erection, ejaculation? What is your combination treatment for large prostate who is not willing for surgery? Of course.
You highlighted a very important point, and I think we tried it surgically. You know, there is ejaculation preserving TURP.
Yes.
Where you receive, you just spare the 1 centimeter above the verumen time and around. And Alosi et al., they published this one very fantastic paper and with live ultrasound, ejaculation, etc. And they claim that it works. I personally tried it several times and it works. This means it's not only the bladder neck, rather than the apex of the prostate, where the ejaculatory muscles are there, pushing more semen outside. Back to the point, if you have a patient with large prostate and you do combination, either to go for alfuzosin plus tadalafil 5 milligram, or start with tadalafil 5 milligram first and see how it goes in terms of improvement of the symptom score, improvement of uroflow, and post-void residual urine, and above all, the quality of life, because you are treating quality of life. And our results should be meaningful to the patient and not to me. I might be happy with the Euroflow, but he's not happy with his life.
Yeah.
So our results should be meaningful to the patient.
Yeah.
So I will start first with BDA5 inhibitor alone, and if not, I can add.
So and tadalafil will be slightly better combination for patients who asks for retaining sexual functions seriously, and also if the prostate is medium to large, can we skip adding dutasteride for some time being?
Yes,
If
yes.
there is no
100%.
harm, and you can
Yes.
try later on
Yes.
after you adjust with this type of medicine. No need
That's
to
right.
hurriedly start heavy combination of medicines.
Yes.
Be focused
Yes.
on the need the patient wants.
100%. But in combination therapy, as you know, MTOP study, there is 5 risk factors where you have to start combination fixed dose combination therapy from day one. But if you look into these risk factors, is nearly 90% of our patients.
Yeah.
Like prostate size of 30 gram, patient 50 years and above, PSA 1.5, IBS score of 17, and Euroflow of 10. This is 90% of our patients. Can you imagine patient with 30 gram prostate, 30, and you give him combination therapy? So if you look into the literature and the compliance of the doctor with these guidelines, only 25% agreed on this.
Yeah. They stop
So
it.
they said, let us go for a step-up therapy. Start with alpha blockers, maybe BD5 inhibitors, and then, if not, then go for the dutasteride. But please, don't be late than 6 months. Patient
Yes.
will not benefit. If you add combination therapy for a patient who is due for this one, and you decide to postpone, not more than 6 months. Otherwise, the patient will not benefit from this combination therapy.
To continuation of this discussion, most of the patient, when they use alpha blocker plus or minus dutasteride, after 3 months, they get phenomenal response. They stop it, and the response will be there for 1 year to 1.5 years. After that, they'll come back again, saying that again same symptoms appeared. When we ask them, they say, you never told lifelong. You have given 3 months. I have used it. Stop. But 1.5 years, I don't have problem. Can I take again 3 months and leave it? This is also by many people.
By the way, this is a study, NICE 1 and NICE 2. There is 2 studies about this one. You
Yes.
start like interrupted therapy, hormonal therapy in prostate cancer.
Yes.
Intermittent hormonal therapy.
Yes.
The same, they tried this one, tried the protocol, and they give intermittent therapy. And more recently, they have like a protocol of interrupted alpha blocker tamsulosin, for example.
Yeah.
They tried to give patient tamsulosin, loading dose for 2 weeks. And then they continue giving tamsulosin 1 day and 1 day off, every other day. The result was the same with low sexual side effect, low ejaculatory problem. So what you said now is translated into studies. Yes, patient experience. That's why we are learning from our patients every day. If you listen to the patient, it's already in the literature. They said interrupted therapy, it can go. Of course.
Great. Great. Do you think, my 8th question, do you think monopolar TURP, when you do aggressively monopolar TURP, I have feeling that erectile dysfunction happens in majority of the patients. We don't know why. They say that after that, my feelings about sex have decreased, my semen amount is decreased. The second one is expected, we can convince. But there should not be any reason patient undergoing TURP should go for decreased erectile dysfunction. Do you think that the monopolar cautery can affect, especially around the apex? We know the nerves are there at the apex. Can there be a logic monopolar aggressive TURP can cause?
Yes, for 2 reasons. Number one, with the monopolar, the patient is in the electric circle. So electric thermal injury is going transmitted into the nerve at the apex of the prostate because the patient is part of the electric circle. In bipolar is only in the sheath or between the loop and the sheath. So it's not going to the patient and not contacting the prostatic tissue. Number two, working with monopolar is slower. So you take more time and more contact with the prostatic tissue, more contact with the electric circle. So I think it's a thermal induced injury due to the long time and having the patient as part of the circle.
Yeah. My last couple of questions. In your private practice, the evolution of TURP, and then of course you might have done open surgery as well. I'm not talking about it. I have not done much open surgery.
No, I did.
I have not seen much Millins or prostate, unfortunately. But monopolar, bipolar, then TUIP, then enucleation, then different type of lasers. Now minimally invasive surgeries have come. What is your favorite surgery to relieve the symptoms of LUTS obstructive predominantly? What is your favorite surgery for a 60 to 80 grams average? I'm not going to the extremes. I'm talking about 60 to 80, 90. What is your favorite surgery?
To answer this question, the key is patient selection. Patient selection and patient selection. No one size is fitting all. When the patient is coming to you now, it's social media driven. Patient is coming with video clips saying, come on, we have surgery to relieve your prostate with 5 no's. No incision, no cut, no bleed, no catheter, no sexual dysfunction, and no anesthesia. Come on, we don't have something in medicine like this, which is 100% the success. So the patient is coming already, and this is the high demand, and you see it in your practice every day. Now, the patient in our area is interested in keeping his ejaculation. That is the most important, because in our culture, he can be married with three and four. Maybe one of them is still very young. So we're starting asking the patient, do you want to preserve your ejaculation or not? If yes, then we'll forget about other options. And of course, he cannot take everything 100%. We have to outweigh the result versus the patient needs. What I first do, I will do check cystoscopy, flexible cystoscopy, for the anatomical mapping of the prostate, to see if it's on the bladder neck, kissing loops, middle lobe is enlarged or not, and the optical field, how long is the optical field if you decide later on to inject resume or to do urolift, etc. Now, if the patient wants to keep ejaculation, and I have to tell him again, look, there is no 100%. You will lose ejaculation in 25 to 30% maybe. Then you have resume, you have urolift, and you have prostiva. Now this radiofrequency ablation is coming back. And we started to introduce now aquablation, which is still, we're starting, we don't have major experience. Of course, we'll go away from ablative surgery, which is resection, enucleation, resection, etc. So as I told you, number one, patient, prostate, and doctor experience. This is the triad.
Very good. And a little controversial is the guidelines have never included cystoscopy findings into the prostate at all, but unofficially 80% of the urologists does it before surgery.
Yes,
You
I think it's important.
You cannot say it is blunder by doing cystoscopy. It's okay if you assess if the bladder is highly trabeculated and the mucosa is edematous and the prostate is the edema at the bladder neck and it clearly shows obstruction. I prefer something ablative surgery.
100%, I agree with you.
100%.
And you tell the patient, and he has to decide.
They live happily
Yes.
after TURP or enucleation because entire bladder is trabeculated. Otherwise, if the smooth bladder is there, widely
100%.
distensible bladder, then we will try to be less aggressive. So
I agree.
cystoscopy must, as you said, the first time I'm hearing cystoscopy also important.
Yes, 100%.
The teachers say cystoscopy is misused for money, earning money, should not be included as part of this thing. But as cystoscopy findings are also important,
100%.
even an office cystoscopy is also okay.
Yes, office cystoscopy. I'm talking about office cystoscopy.
Yeah, flexible cystoscopy is okay.
Yeah,
to
100%.
give idea to the patient that how severe the mechanical part of the look, at least look. My last question. Recently, there was a discussion that the guidelines are changing because the prevalence of the disease pattern is different in developed countries. They will not look which is ideal. They will look at the disease prevalence. For example, the stones are not treated by PCL in Western countries because they don't see stagger. From the birth, they are doing ultrasound. Whereas East, Middle East and the Asian, still we feel a lot of burden is there. So their research is limited to the minimally invasive surgeries than standard traditional surgeries. If this is the thing, what is going to be the future in the science? For example, if small tumors are detected in kidney, they are saying don't do anything. We can use radio frequency ablation. Now they are saying small tumors in the prostate, you can
Focal therapy.
focal therapy, even one side removal of the gland by
Oh,
robotic.
yeah.
One side removal of the gland by robotic, because every day you are on watching the PSA every day or closely. So in BPH and this thing, after certain years, we don't know whether TURP and enucleation will be encouraged by the society which will declare the guidelines. Usually these societies are affluent societies.
Agree 100%. Agree 100%.
So
And now I think the more knowledge we have, the more modification of the guidelines. Nobody could imagine that we have kidney tumor, biopsy proven, and you put the patient on surveillance. Right? Now there is literature saying nothing to be done because they have comparative studies. Nothing happened because slowly growing tumor, especially in surgical unfit old patients.
Yeah, I have seen young patients while doing RIRS, very high bladder neck. Your scope not able to go into bladder, but still no symptoms at all. No, zero symptom. You have high bladder neck. Your orifices are not seen.
Yeah. So every day, I think the face of medicine is changing for two reasons. Number one, the successful medication we are having right now. For example, in the prostate, we have too many medication which was not existing before. And this, I think, take the burden. Very few will need our intervention right now.
Yeah.
Number two, the push of the industry. Medicine is now industry driven. So every day, look at the scopes. I'm following you. Last time they did this ureteroscope with intrapelvic pressure and temperature monitoring. Look how they are thinking.
Yeah.
So they are just
We
pushing.
We never thought of those things.
Yes,
now, once you give it, you'll think about it.
Yes, 100%, 100%.
So to conclude, thank you very much. You have a lot of knowledge. I understand you are studying the papers very well. Really happy that Tariq has referred your name.
Thank you so much. Thank
you.
you.
Get connected with the seniors, juniors.
100%.
Ambition, research.
100%.
So get more connected, because everybody may not get opportunity in the conferences. This is zero cost job. This video will be there for forever in the YouTube. And those who are interested, like exam going students who want to write BPH with sexual dysfunction, they type,
100%.
your talk will come. This talk of 20 minutes, you keep earphones and listen, you will get gold medal.
Agree 100%. Agree 100%.
Great.
It's my pleasure sharing with this activity. Thank you so much, Dr.
Thank
Chandra.
you very much, sir.
Looking forward to more cooperation.
Yes,
and
sir.
You and your team are invited to our next scientific activity here in Dubai.
Yes,
it
sir.
will be in April. I will invite you as a speaker to get some of your knowledge. We have two major conferences in a year in UAE, and I am the scientific chairman. The first one is the Emirati Association of Urology, and every year we are hosting one of the international societies. Like video urology, endourology, and next year we are hosting the International Conference Society.
Yes, sir.
But we have another forum which is urology for non-urologists.
Oh.
So we are interacting with urogynecology, medical oncology, GPs, and all this. We are collecting these people in what's called IUCC.
Okay.
Interdisciplinary Urology Care Consortium.
Great.
It will be next April. You will be invited, and I will be happy to attend and give us a lecture there.
In April, Isam from Egypt is invited for this Egyptian National Conference to conduct EC.
Excellent.
The dates will
maybe we can connect the same trip.
But recently, if I see Arab states and the Southeast, East, doing a lot of research.
Yes, major changes.
Skills, your communication skills are far excellent, and a lot of people are studying and writing the papers. A great change in the developing countries as well. Of course, they are developing, but a lot of enthusiasm in academics is seen. Youngsters are following. I really
agree 100%.
I really appreciate the Arab
Thank
Emirates,
you. Thank you so much.
Saudi Arabia,
Thank you.
and
Thank you.